That's it started now, Mike.
Thanks, Sue. So questions can be asked at the end of the presentation by putting a virtual hand up, or as we go along, so that you don't forget it, you can write it into the chat box. And I'll pick those up first as we go through at the end, once Radhe's finished her presentation. If we run out of time and you still have a question, feel free to email it to the email address that you sent your request for a link to, which is membership@swift.nhs.uk, and we'll try to get answers back to you. We'll also send out copies of the presentation itself. So now I'd like to introduce Mrs. Radhe Raghavan, who's a consultant gynecologist, and hand over to her to start our presentation.
Thank you, Mike.
If everyone could be muted, and that'd be great. Thank you.
Brilliant. Thank you, Mike, for that introduction. So if I start by sharing my slides and then start from the beginning. Okay, you can see my screen, I think. So good afternoon, everyone. Thank you for joining. So my name is Radhe Raghavan. I'm a consultant obstetrician and gynecologist. I have special interest in menopause and HRT, and I'm going to just share some slides with you guys for the next half an hour, and happy to take any questions at the end, as Mike said. So what is my experience of menopause care? So I have been a gynecologist for about 20 odd years now, or more, 25 years must be close to. So what I have seen is menopause care has really revolutionized especially in the last decade or so. I must say the problems of menopause is more spoken about, and menopause is thought to be one of the differentials for a lot of problems that women can come with in various other specialties as well. So it is a major life event. We were not thinking of it as a life event in that sense, and not putting it down to menopause causing a lot of symptoms previously. But for us now, we know that it can cause a lot of symptoms which can present in various ways, and women can go into various other specialties with various problems, which can affect any part of your body actually. And so it is important that we acknowledge the menopause care and put it right as much as we can. So it is hence important that as health service we all have a basic understanding, and we have a basic awareness of how menopause can affect women. So it is for our patients who we care for, as well as our own workforce. So it can affect women in different ways, or some women it may not affect them to any extent at all. So it is important to have that awareness. That's all. So what we need to do is, we have come far, as I said, from when we started looking at menopause care a decade ago. But then what we still don't have is clear referral pathways between services, and we still are regrettably, there is resources is really inadequate to meet the demand. So you will see a lot of wait when you want to see a menopause specialist on the NHS. So it is probably got some work to do, if I can put it that way. So what I was hoping to just touch on in the next few minutes would be just to talk about how we actually diagnose menopause and various symptoms women can have when they are having symptoms with menopause, and also as specialists, what can we help women with? So in simple terms, when women stop having regular menstruation, it is menopause. We normally wait for up to a year before we can diagnose that. The age of menopause in the UK is on an average 50 to 51 years. However, some women can continue to have regular periods even later on into their 50s. On the other hand, some women can stop having periods as early as less than 45 years. So when we have it as early as less than 45, we call it as early menopause. There is a condition where women can have this kind of a condition even before they turn into 40 years of age, and that can fortunately be a less common condition, affects 1 in 100 women. So that is basically what we go with when we diagnose menopause. So we don't necessarily need any fancy blood tests, anything investigations wise. So if somebody comes to us, as long as we are aware that these symptoms could be due to menopause, then we as specialists will probably have a we don't necessarily need to do any major blood tests. However, there is a condition called, or a period of life, what we call as perimenopause, which can be quite variable in terms of how long it can take. Some women can have perimenopause for lasting as long as 10 years or even longer. So they do have all the symptoms, but if I go by the definition, they're not menopausal yet. So in my experience, these were the group of women who were struggling a little bit more. And also, unfortunately, even now, the help is not that forthcoming for these women because we don't diagnose them as menopausal yet. But since they have all these symptoms, they still need the help from menopause specialists or with even GPs. So I think that is something that I've identified as an area to focus on in the perimenopausal age. But as I say, once we diagnose menopause, then sometimes it is not as difficult to seek help. But as I say, we have gone a really far distance with this. So fortunately, there is help. If somebody has had their womb removed, either surgically or any other way, then obviously we would just not be able to go with the periods itself to say whether they are menopausal or not. So what we tend to do then is to look at all the symptoms. So when women, fortunately, not everybody who has menopause will have symptoms that they are not able to tackle with simple measures that anybody would take for themselves. But then there are a significant proportion of women who do need some help. So what we need to understand is that not one size fits all. Hence, so the menopause care is really, it can be quite complex in some kind of medical conditions. And there is lots and lots of options open for women. And because not one size will fit everybody, even in their different stages of their menopause, so we have all these options. So we will just look at all this in a little bit depth. So when I say alternative therapies, I'm sure if you walk into any of the supermarkets or some specialist clinics, out of over-the-counter medications, you will be able to find a lot of help out there that women may want to try before they actually seek any medical help. So I just wanted to see what the evidence is about any of these being helpful or otherwise. So if I go back a step, where are we with the menopause care? When I said this, there was the quite important NICE guidelines that was initially published in 2015, which is where most of our recommendations are still coming from. Obviously, there has been lots of things that I've added to these guidelines since it started, but then there's the first guidelines that was really quite helpful for us as menopause care. So I think before that, there was lots of papers, lots of publications which were there from early 2000s or even before really, but they were sometimes contradictory and not very clear to understand. So the NICE guidelines with regards to the alternative therapies, it says that we can still find some evidence, but it's not very strong, that some of these medications that you can buy over the counter could help with something called as vasomotor symptoms. So these are symptoms where women have hot flushes and night sweats, which stops them from getting on with their routine. So what is not very clear is the long-term efficacy and long-term effects of these medications. But nevertheless, it is still in the NICE guidelines as a treatment option for women of certain group, if I can use that word. It may be the only and the best option for them. But these are considered to be harmless therapies because we don't know if there is any long-term effect that is recognized. So we don't have evidence to say that there is any harmful therapy, harmful effect from these over-the-counter medications. However, what we need to be aware of before we advise on this is that there can be some conditions where there can be some side effects which could potentially be life-threatening. I have in my experience seen one lady who was on warfarin and she went on to buy St. John's wort from over the counter. And unfortunately, she had a very severe bad reaction because we know that it interacts with certain medications. So because women are probably picking this from over the counter, we need to be more aware of these interactions. It's not only warfarin, there's a whole list of medications that it can interact with. And also if somebody is on a contraceptive pill, as I said, if they are perimenopausal or if they are even in the early menopause, they might want to continue with the contraception and they will have adverse bleeding effects with these over-the-counter medications. And if somebody, I've also seen a lady who started to have her epilepsy attack recur after many, many years when it was actually very well controlled. But when we actually went in to dig in to see what has changed, actually what it was is that she was buying some over-the-counter medications to help with her menopausal symptoms. So we know that it can reduce the efficacy of these medications. So these are the things that women need to be kind of aware of before they just go and pick something from over the counter. And also, obviously, what else is the high cost sometimes that it can entail when they are buying this over the counter medications. I have a lot of women who come and tell us how much they have already spent without much benefit. Because they do want to try one after another to see if any of the medications would be any good. So what this can do is when they have no help, then unfortunately it can develop into a disappointment, disillusionment. Sometimes women can become depressed before they actually get the correct help. So that is the herbal medications, but we also have some non-hormonal prescription medications that we can help with for some menopausal symptoms. So we have a group of medications which can help for various symptoms. So it depends very much on the particular symptom that this lady is getting. So there are some few trials, unlike the herbal remedies, where we have very little evidence or safety data. There are quite a few good trials that we can find within the NICE publications, which has said that these medications can be effective. But overall, the effect of these non-hormonal medications are considered to be less than the traditional or conventional HRT that we'll come to in a minute. There can be adverse effects like any other medication, unfortunately, with any of these non-prescription medications as well. And again, the cost implications with that. So herbal remedies, obviously, it can be the best medication for some women. It also depends on what symptoms they get and what the relief they have found with it. The only good two medications over the counter, which has got good safety data and some evidence to support that they are effective, is the red clover and soy isoflavones. But none of the other medications have got anything as a scientific evidence backing that. Also, what we need to, if somebody comes to me in the clinic and says, do you think it's safe? Then what we say is we don't know the chemical analysis of these herbal remedies. So I don't know, unlike a HRT, I know exactly what dose of estrogen I'm giving somebody and what dose of progesterone I need to give, etc. But we don't have anything like that for herbal medications. So unfortunately, we do not know how much estrogen anybody is getting with this. So alternative therapies, there is something called as a cognitive behavioral therapy, which is also recommended by NICE, and it is a very good proven evidence to help for women who have specifically anxiety related to menopause. So in my experience, I think it is again a little bit difficult to get access to CBT. However, it has improved significantly from a few years ago. So there are some GPs who would offer this CBT, and counselors, trained nurses. So there are lots of self-help books. So they do have some sessions and they have reviews after that. So I think there is definite group of women who will benefit with this. However, moving on to the HRT, which is where we come in as gynecologists, most women who would come to see us would have probably tried most of these things that I've talked about before they actually have an appointment with a gynecologist or even a menopause specialist. So HRT, the NICE guidelines is unequivocal about how HRT can be effective in treating these symptoms for women. However, just like what I said earlier, there's not one HRT that fits everybody. So we need to individualize based on what symptoms they have, what personal risk factors they have got in terms of any medical comorbidities, and also what family history they have got. So overall, based on this where we can probably individualize what HRT may be best for somebody. So what does the guidelines say about when is the HRT most helpful? I think there is evidence to say it's most beneficial if you start before age of 60 or within 10 years of menopause. But having said that, it is not it's not unusual for women to go for the first time on a HRT in their 70s or I have got a lady who is, I think, 84 this year, who is come to see me because she thinks HRT would help her. So it is not unusual for women to seek help even at that later years of life. But usually we know it is most beneficial if we started within 10 years of menopause. And again, how long can you continue HRT? Again, NICE guidelines is very clear that there is no arbitrary time limit. So it is very different for women in terms of what are the personal factors they have, whatever the personal stress, etc., that is happening in their life, for example. And then obviously, I had a lady who was turning 670, and her GP kind of was not supportive of her to continue with the HRT any longer because of her age. But she came to seek help because she said she was looking after 2 young grandchildren on 2 whole days, and she just couldn't find the energy to do anything with the children, with the little kids. So she was just struggling a lot without HRT. Not that it's going to be a miracle drug, but at least it was helping her a little bit. So even at that age, she chose to continue on the HRT. So there's no arbitrary time limit for anybody to stop HRT. So we do start it for various symptoms. Essentially, that's the first condition first indication why somebody would be considered to have a benefit with HRT. However, having said that, if we have a woman who doesn't have any symptoms, but she's had a menopause before she turns 45, then we know the HRT can help with the bone health. So we do start them on HRT without waiting for any symptoms. Sometimes we do a surgery where we need to remove both the ovaries before the menopause. Again, it is important that gynecologists do consider starting them on HRT before they send them home. So there is a role for HRT as a preventative option for osteoporosis, but again, it is not the first line for this indication, because there are other preventative options that women can have for osteoporosis itself. But again, it's known to be helpful for that. So, but there are certain conditions where we sometimes think it is very risky to give HRT. I mean, obviously, pregnancy and breastfeeding, it is not applicable to give it. But if somebody has had any cancer, again, this is one area where we have seen a lot of development in the HRT advice itself. Previously, if it used to be like if you have had any breast cancer, no HRT. It used to be a blanket advice, almost coming up like that. But as you probably know, breast cancer is usually a cancer which affects young women. So you cannot let them suffer with the symptoms after the treatment of breast cancer. So we do have specialist menopause clinics that we run to help these women to see what best can help them. Again, like any other condition, it depends on what type of breast cancer and how soon after breast cancer and what symptoms, etc. So we can tailor and help these women with the symptoms. And also if somebody has had a blood clot or if they have any history of stroke, etc., we need to be cautious with HRT. Again, I can't think of any one reason where you will say no HRT at all, because if not HRT, there are other things that we can help women with. So what we face in our HRT clinics is obviously the decisions that we need to make, because everybody, as I say, each woman in front of us is different. And what may be perfectly, absolutely good for some women, the same HRT may not work for them. So that's where we come in. So always what we take approach is to say, is HRT absolutely the only choice? Or have they tried anything else? Because even though I said lots of women may have tried other options before they come to us, it is not always the case. Sometimes women, they don't even look after themselves in terms of getting into a normal BMI, etc., stopping smoking, alcohol, simple things like that, which obviously we do advise them on, lifestyle measures. And then we go on to advise on these. Almost we take like a stepwise approach to help women with these symptoms. At least in the last few years, what we have seen is become a very significant proportion of gynecology work is bleeding on HRT. So even though HRT is helping women with some symptoms, the most annoying symptom that women find is often the bleeding that they get with the HRT. So again, this is we do at least have 2 or 3 clinics every week, and a significant proportion of women in those clinics would be women who are having unscheduled bleeding on HRT. So obviously there is a worry and scare about cancer being a cause for the bleeding, but of course it can be simple things like, HRT needs tweaking. So we do have a significant proportion of women who get really annoying symptoms like that. So when we prescribe HRT, obviously we want to see whether anybody who has got a womb, we always need to give them progesterone as well, because if you give them just the estrogen, then it will make them, they will have a thickening in the lining of the womb, which will make them bleed more and also can give them a risk of cancer of the lining of the womb. So we do always give them a combination if they have not had a hysterectomy, that is removal of the womb. Fortunately, we have a lot of choice with HRT. We have the various doses that we can use, right from ultra low dose, moderate, high dose of estrogen. And also similarly, the progesterone can be taken in different forms and different routes. So yeah, I think there is hope is what I can say, because if one HRT is not working for someone, then there is always something else that may be better, worth a try. However, it is not always that easy to get the right HRT at the start. We do have to do lots of tweaking, and obviously some women who find the patches is the best thing for them, for somebody else it may not be, because I have had some women who would swim maybe 2 or 3 times a week, and obviously the HRT patch may not be sticking very well, and hence they feel that the symptoms are up and down, because whenever the patch is not sticking on their skin well, then they don't get enough hormones. So it is very dependent on what symptoms they are getting and how best we can give this. So obviously there's just to say how many different doses we can get of estrogen and progesterone and the pump pack. There's also a sachet. There's a implant also available for all these, but implant is usually reserved for women who don't respond to any of the other options. So Why do we give progesterone? As I said, is mainly to make sure that we don't stimulate the lining of the womb too much with the estrogen. However, most of the side effects we know are related to the progesterone, and the risks that we get, like the risk of breast cancer, which is a big one, is also related to the type of progesterone that women take and for how long they take it. But then obviously we know it's important to give them progesterone, and hence we do give them progesterone, but it is to see what progesterone would be the best for somebody. So what we do always is to take this risk balance approach. We want to see that we're not doing any harm is the bottom line, first of all. But if we can do any benefit, then obviously it depends on what symptoms there are and how much of a benefit any particular HRT is giving them. The biggest scare for HRT is the breast cancer. In the early 2000s, I must say, there was a big scare about HRT. I was just being a gynecologist, recently started practicing at that time. I can see how practice has changed now. At that time, women were just very, very scared to go on HRT because of the worry of breast cancer. So we know now that it was probably down to some studies which were not really extrapolated in the right manner. So it was perceived to be a risk of breast cancer. But now we know a lot more about breast cancer. So this is something that I show my women when they come in and being worried about breast cancer. So if there is a lady in the age of 50 to 59 years, let's say, in the UK, 23K women out of this 100,000 women can get breast cancer without any exposure of HRT or anything at all. But if they are on HRT, you will see there are 4 additional cases of breast cancer within the same group. So in the big scheme of things, the risk is small. But if you just compare that to something as simple as, for example, drinking 2 or more units of alcohol, again, there is 5 cases more of breast cancer in this group compared to somebody who is on HRT. So you can see simple things like what you can change or what you don't perceive as a risk is actually a risk. But if you look at this BMI, for example, if we have a BMI more than 30, you have 24 additional cases of breast cancer in this group. So once I put this infographic in front of the lady, then it makes them easy to understand, and the perception can be a little bit different. So it just to help. So this is something that is from the British Menopause Society. We do, as menopause specialists, often show this to our patients when they are worried. So within the last few years, what has become a little bit more prevalent is the androgen replacement as well. So despite estrogen and progesterone, some women may have some symptoms which is not corrected. Especially some women have symptoms with low sexual drive and also brain fog, excessive tiredness, which is not corrected with the traditional HRT. So we do have this option to help women with the testosterone. But again, it is not licensed in the UK, unlike in some other countries where it is licensed. Hence, because it's not licensed, it is not something that the GPs would start unless they are a menopause specialist themselves. So we do have unfortunately, a bit of a waiting list for women to see menopause specialists when they're wanting to start testosterone HRT on the NHS. So bottom line, it's a milestone really. There is lots that women can have, and lots that menopause specialists need to learn, need to revise themselves, and also there is lots of self-help group, etc., that we can signpost women to. So we do take a combined approach and then see what best we can help this lady in front of us. Not to forget, there are lots of vaginal preparations that is also quite important in some women really. So I think we are half an hour now. So what I thought was, if there was no questions, then I had some cases of ladies that I have looked after in my clinic. But what I'll do is I'll stop sharing and then see if there are questions, we might as well go through them in the next half an hour.
Thanks, Roddy. There are a couple of questions that have come in already.
Sure.
So they're quite similar, but I will read them separately. How do we get to see someone at the post breast cancer clinic for HRT advice? And interestingly, that's the thing that I wrote down as well, because I've got a neighbour who's in that situation.
Sure. So we have a good number of menopause specialists who are recognized from the British Menopause Society. So some of us do practice in the local area, obviously, as well. But within the NHS, I can talk about where we are with Warwick Hospital. We have a couple of consultants who are menopause specialists, but we haven't, advertised it as a menopause clinic, but we do see them within our general gynecology clinic. So essentially what these women could have get is to get the GP to refer them to the menopause clinic, and we will be able to help them.
Okay, thank you. So the second question in the chat box is, I will read this in full because the person's put it in text. It's from Donna. How do I access a clinic when I have zero faith in my GP around HRT and my history of pulmonary embolisms, stroke DVT and lifelong anticoagulants? The advice I got was, it's your choice and there may be an increased risk. She doesn't have any medical knowledge herself and doesn't have confidence to make the decision herself. So the other option was suggested was antidepressants, which angered her because she's not depressed.
Absolutely. Yeah, Donna, I think this is a very, very common scenario I see in my menopause clinic, unfortunately, because as I said in my presentation, sometimes women have tried a lot of things before they actually feel a bit desperate for some specialist help. So I can totally empathize with you when you're saying you're feeling angered and depressed, but you're not actually depressed. It's just the way situation is not being helped for you. So I think what you might need to do is to get your GP to refer you to the menopause clinic. And as I say, I think hand on heart, it would be nice if we can give you a little bit more, easier access here. But we have, unfortunately, at least 6 to 8 months wait for some of the clinic consultations, which is sometimes a bit too long for anybody to wait. But we do run a menopause clinic service, so we can get your GP to refer you to us. And we will be, as I said, there is history of pulmonary embolism and DVT and lifelong anticoagulants. None of this is an absolute no for HRT. So we will have to sit down with you and see what HRT would be best. But in general, for women who have had such a history, we do think giving HRT as a through the skin, like as a patch or as a gel, would be better compared to an oral tablet. Because we know when you take it through your skin, it doesn't get through your liver for digestion, and hence it does not upset your coagulation further. So yeah, definitely you can get HRT, but I think get your GP to write to us if they are not confident with it.
So in the chat box, Donna said thank you. So I've got a couple of hands up, and then I've got another a comeback question from the first questioner. So I'll do the hands up first, and Carolyn, you were first in.
Yeah. Am I audible? Yes, I am.
Yes, you are.
Yeah. I just two comments. First of all, thank you so much for a fascinating and very useful presentation. It was wonderful to see all those options that you're offering. But secondly, a heartfelt thanks on behalf of half the population of the world that this is being taken seriously now.
Yeah.
And I'm glad to see that men are here too. It is a very serious condition. Personally, I didn't suffer, but I know that many people did. And thank you so much for taking it seriously and helping so many people.
Thank you.
Thanks, Carolyn. Louise, you got your hand up.
Yeah, sorry, I can't access the chat for some reason. Anyway, hi, thanks for that. I facilitate the Kenilworth menopause group, which is a peer support group for patients. And one of the things that comes up quite regularly is discussion of anxiety. And I wondered if you could say a little bit about the use of testosterone for that. The other thing I was going to ask is I've heard of something called a Women's Health Hub. Have we got any of those locally, and what are the plans? Because I'm concerned that there's such a long wait to get to see you at Warwick.
Yeah, sure. So the first question about testosterone for anxiety specifically. So the way I would approach is to say, are they on traditional HRT, which I assume they are. That what I mean by traditional is estrogen and progesterone. So what we need to do is, anxiety is typically a estrogen deficiency symptom. So it's not a testosterone driven symptom. So that doesn't mean that they can't get testosterone, but it may be that whatever estrogen they are taking, they are probably either it's not enough, or if they are taking enough, but it's not being absorbed. So I have had some women who will be just almost taking 4 or 5, 6 pumps of estrogen, but despite that, when you check their estrogen level, it will be, we would expect it to be something around 650 picomole. It would be something very little less than that, really. So what that means to me is, actually, even though they're taking lots of estrogen, they're not absorbing it. So what I would do then is to probably check if they have, if they haven't already had a blood test, then that's the first thing we would do. And while we are doing the estrogen blood test, we can always check the testosterone as well. So the testosterone, unlike the estrogen, we need to monitor the dose, monitor the blood hormone level, testosterone level, because if you have it more than the upper limit, you could start to develop symptoms of side effects. All right. So I have had a lady who felt really so good on the testosterone that she actually took it as much as the estrogen. So, you know, even testosterone needs to be taken very little. But she felt actually, yeah, this is good. I feel good on it. All my symptoms have gone. So, but unfortunately, within 2 or 3 months, what she started to have is acne in the face, facial hair started to grow. Fortunately, none of this is going to be a permanent side effect, but then we need to monitor it. So for this lady with anxiety, that's what I would say. I would want to see what estrogen she is on and whether she has got enough estrogen in her bloodstream. If it is not, then it could be something as simple as if she's taking a transdermal preparation, it's not absorbing. So we might need to change the route of HRT. Some women, we also have an option of, they won't tolerate the oral HRT, and the transdermal is either the patch is not sticking or causing skin irritation, and the estrogel is not absorbing. So the only other option is to have it as an implant. So we do, unfortunately, don't have implants on the NHS, but we can help this lady in the private sector if that's the only thing that's going to help her. But yes, testosterone may be an option, but before that, check the estrogen. With Women's Health Hub, I think we have been having some gynae network meetings recently, and what I understand is that they are, yes, it's very much there, but they are also developing a bit of a waiting list. And so they are not, you know, directly seeing all the women when the GP refers. The GP would normally refer them to Women's Health Hub if the appointment is available there. But I think they have got a bit of a demand that they are not able to meet as well. That's what I hear from the GPs. So they are specialist GPs.
Where is the Women's Health Hub?
It's not a physical space from what I understand from them. They are a group of GPs. I've been in touch with a couple of them who are who've got special interest in women's health in general. It could be menopause, it could be some other conditions of related gynae conditions as well. But they have a digital hub basically, and they have a streamlined pathway of GP referring patients directly to them. And most things they are able to sort. But like us in the secondary care, they have got a bit of a waiting as well. So, but yeah, certainly there is a Women's Health Hub that I think most GPs would probably know that there is a route of referral there as well.
Thank you.
Thanks, Louise. I know that Rhiannon has posted a link to Women's Health Concern, which is the patient-facing arm of the British Menopause Society. So you might be able to find some stuff there as well, Louise.
Absolutely.
So I've got Back on the questions, I know Jean's got a hand up, but the questions came in first. So Nick came back talking about breast cancer. Is there an HRT option for someone who is struggling really badly with symptoms, but has had breast cancer that is estrogen linked?
Yeah, so yes, there is definitely an option. Recently, I didn't put it in my presentation because didn't want to give too much details. Obviously, I thought it may be useful to talk to the talk regarding the questions. But there is a medication called fezolinetant, which is recently approved for women on who have breast cancer. So the bottom line is, if there is breast cancer and if they've had a disease-free interval of more than 5 years, then almost we are a little bit less anxious in giving them HRT if that is the only thing that helps them, that's helping them. But if not, we have a medication called fezolinetant, which can help significantly with, especially with the hot flushes and night sweats. Obviously, it's usually a vicious cycle. Obviously, they have a night sweat, hence they don't sleep well. And then that carries on in the day that they are not able to then function well because they have not had a good night's sleep. So it's often to break that vicious cycle. So yeah, there is that medication that I have had some experience with, and women have found it helpful.
Brilliant, thanks. I've just realised that the link from Rayanne was in response to a question from Christina about useful resources out there. So hopefully that's answered her question. Right, Jean, you've got your hand up.
Thank you. Just like Carolyn, is heartfelt thanks to people like you who are bringing us out of the dark ages. I went suddenly into menopause when my mother died unexpectedly, and I had every symptom going. And while I was at work, I had severe headaches, which I haven't heard you mention. And I couldn't think for them. They were so bad. And I was frightened to bend down and stand up suddenly. And I was at work and talking to somebody and suddenly started to talk gobbledygook and then collapsed and was admitted to A&E, where the consultant who I knew insisted that I had a brain tumour. And when I said to him, no, it's the menopause that's been brought on suddenly by my mother's death, he actually laughed. I mean, we knew each other quite well. I'd worked in A&E. And he couldn't believe that I'd be so stupid as to say something like that. I actually discharged myself the next day and told him it was definitely the menopause. And it carried on like that. And when I went, I persuaded another doctor, my GP, one of the practice, to put me on HRT. They didn't want to. And then just a few years later, another member of a partner took me off HRT. Even though I said I really objected, it didn't matter. She stopped the prescription. So, and lots of things like that. So I just want to say to you, thank you. It really was the dark ages, and we've still got bits of darkness around, I think, but you're bringing us out of it, and presentations like this make people more aware, and I'm just so grateful. Thank you.
Yeah, thank you, Jean. Thank you for that. I totally agree with everything you're saying, and thank you for sharing your own personal story as well. Yeah, it is not really unusual that I might see one or two women with this kind of a story where they've had a long struggle before they can actually get some help. So it's going out there, I must admit, because GPs are awakening to this as well, hopefully. But there's some hotspots still are more better than others in managing menopause in general. But having said this, when you said headache and all this, I think I am obviously a gynecologist with menopause interest and all this. I would be looking at it from this point, but I have been caught twice actually in my experience where somebody came in with headaches like this, and then everything was put down to possibly, yes, you have all these things. This is the trigger. Yes, you could be menopausal, but not to forget, there could be other things as well, you see. So as I said, 2 cases. I've seen one lady who had a meningioma diagnosed on the MRI head. So I would actually help them with the menopause. It is very likely from what they are saying, but then always do the investigations to make sure you've ruled out other things as well. But yes, absolutely take your point on that.
Thank you.
Oh, Christina's got her hand up.
Hi, Radhi.
Hi.
It's just to follow on the second part of what I put down about obviously the resources, wanting to know about the less known symptoms, because obviously there's so much that's written about things like the headaches and the sweats and all of these other things that are very commonly known, but actually my symptoms have kind of escalated in the last couple of weeks, and some of the things that I've been experiencing I haven't seen anywhere in the text. So some of those that's why I put back the resources. So I thought that'd be useful to raise for some of the people on here if they're actually experiencing things that are out of the norm, that they actually think are something completely unrelated. So one of the things I've had the last couple of weeks is my food tastes mouldy.
Yeah.
And I've Googled it, and it says that it is due to the hormonal changes, and that actually it is a thing that could happen, but it could be related to other medical conditions. It could be related to some of the other like health related issues, but actually it's just the last couple of weeks, and literally I have to rely on the fact that someone else is eating the food and clearly doesn't seem to find the sausages that they're eating taste as mouldy as I think they do.
Yeah.
So it's symptoms like that where they've just been coming at me lately really rapidly, where I'm then having to Google it and say, is this part of menopause? Is this something that happens? So I don't know whether maybe there's somewhere following on from this where we could share some of those things to say, actually, here's some of the unusual things that I'm experiencing.
Sure, I think you're absolutely right. I have seen some women who come in with odd tastes and, obviously skin changes is more common, but yeah, odd taste, I have seen that, but it is a rare symptom. You're absolutely right. So I think the way I would approach it is obviously keep menopause as one of your differentials, then you're not missing it. So by all means, as a medic, you want to investigate what else is causing this. Yes, do all that, but then don't forget menopause could be it. It could be one of the causes when you, so almost certainly you might reach up to it as a point of exclusion of other medical conditions. But nevertheless, when it's all excluded, don't say actually everything is fine with you. It's nothing, it will settle. But think of, yes, everything else is fine. Yeah, whether it could be menopause, then if it is, then you're on the right track to treat you.
Thanks, Radhi.
Thank you, Christina. So Donna's come back. Donna works at Swift and says, would it be useful for all those who manage a team to have some sort of training from yourself, Radhi, or your team for them to better understand the effects that menopause can have on your day-to-day life? I'm fortunate that I have a supportive manager. However, I know many others aren't. You mentioned night sweats, one of the common side effects, and it affecting sleep and the ability to function. And it's so difficult. And if you don't feel supported by your management, it makes the struggle even harder. I've had nights where I've literally had, that's right, someone just posted something, it's jumped up the screen. I literally not slept due to the symptoms, then not felt safe to drive to work. But the worry of sick days, discipline around absence, etc., makes me even more worried. So
absolutely. I think we now I think we need to take this further. And I think thank you for acknowledging the work we are doing, which is very small, really. I think we need to take this further to try and have some perhaps group sessions with the we are actually very privileged that we have got a nurse who is working with us, who's got special interest in menopause as well. So with her help as well, maybe we should start something like a focus group or something for our own staff. So I think that's something that we could perhaps look at as something that we could do in the future. Yes, absolutely happy to be involved in anything like that. But I will think over it as well, Donna, to see how best we can help our managers with this.
So Nikki's come in on this request saying, please share with people our Swift monthly menopause support group held on the first Tuesday of every month on MSTS 2 till 3. It was set up to support staff experiencing perimenopause and menopause. And in June, Nikki's playing a lunch and learn video helping with sleeping problems. Please contact her.
Lovely.
So that's, let me just scroll back up. Sorry, people have commented their names. So that's Nikki Grice, who works at Swift.
Very good. There you go, Donna. That may be something that we need to look out for, I think. Yeah. That's really good, Nikki.
Jean's commented on GP awareness as well. So, okay, I don't see any more hands. So I think we may have come to the end. I have to make a personal comment that HRT in this household has been transformational. So
that's good.
So I will be addressing one of the questions that's just been asked when I read out the next bit from my script, which is, I have to draw the meeting to a close and thank Rede and everyone who's asked questions. I mean, they're all really good questions, and obviously we'll get those documented and out and about. The video will be available on the Trust YouTube channel and on the website in the next couple of days. And as mentioned at the start, there will be almost a monthly regular topic being picked on to be discussed online. So thank you to everyone for attending. I may be hosting the next one. Hopefully some other governor will volunteer, but I might see you again in the future. Take care.
Thank you, Mike. Thank you, everyone.
Thank you.
Thank you.
Bye. Bye. Bye.
Thank you.
Thank you. Bye.
Bye.
Thank you.
Thank you.
Thank you.
Thank you.